the challenge from its infancy. So he's really been around from day one and has played an integral part in today and the first challenge last year. Dr. Snell is a certified physician executive with 13 years experience as Chief Medical Informatics Officer in 2 large Catholic healthcare systems, Trinity and Ascension, now independent and focusing on innovation, clinical integration, care transformation, and virtual care strategies for healthcare enterprises. Also provides development expertise in emerging technologies for entrepreneurial companies. Practiced and taught family medicine for over 20 years in South Bend. Conceptualized and helped build one of the nation's first successful and sustainable health information exchanges. Led projects to deploy electronic records in physician practices, hospitals, and brought remote care to the forefront of accountable care. Dr. Snell.
Thank you, Matt. That's a pretty good introduction for someone who's unemployed, right? Are you having a good time?
Yeah.
Exciting challenges? Great challenges, 3 great challenges. I hope you're enjoying getting to know them better and up close, and have some of those ideas circulating wildly in your brains right now. And so I think you're going to enjoy the rest of the day. Our keynote speaker, Dr. Lyle Berkowitz, who I'll introduce in just a second. And then, of course, we have the panel this afternoon and the Google Glass demonstration. So great day, and again, thanks to all the organizers on the committee. They're listed in the back of your program. Great group of people to work with. I really enjoyed that. So happy to have all of you here. My introduction is really of a longtime friend, Dr. Lyle Berkowitz, and I got to know each other back in the early 2000s because we were both struggling trying to get Cerner Power Chart Office to work in our respective practices. So we would get together and lament over that and try to help that big EHR company with what they were trying to do for physician practices. Like myself, Dr. Berkowitz is a primary care physician, practicing internist with the Northwestern School of Medicine and Northwestern Health System. He's very distinguished in the field of clinical informatics, and you see a lot of his titles on the screen. So I won't go through all of those, but let me just tell you a few that maybe are not on the screen. He actually helped found and is on the governance board of the Innovation Learning Network. So when we were looking for a keynote, I said, I have just the right person that you need to invite. He's also on the editorial board of Clinical Information and Technology magazine. Here's the hard copy. It's also, I have this if you want to take a look. It's also an electronic version that comes out weekly, and he's on that editorial board and a heavy contributor to that. He published a book, which I also have a copy. I've read thoroughly and enjoyed it as soon as it came out last year. And he's co-editor of this book called Innovation with Information Technologies in Healthcare. And it's actually a compilation of about 20 very exciting, creative, innovative stories of how people took ideas, like you're doing today, and turned them into actual solutions. And some of the trials and tribulations that they went through. So I think many of you can probably relate to the stories that are in the book. And then he, of course, provides editorial comments on each of those scenarios that he focused on. He has been selected several times now in Modern Healthcare's top 25 clinical informaticists in the country. And he was also named by health leaders 20 people who make healthcare better. Isn't that a great title? 20 people in the country who make healthcare better. So it is indeed my great pleasure to introduce a very dear friend, good friend. So let's give Dr. Lyle Berkowitz a warm Hoosier welcome. Thank you.
This is when you get your mom in the audience. Thank you. So I love what you guys are doing here. Everyone can hear me okay?
Yep.
Usually pretty loud. I got a little here. So the Healing Edge, I'd like to title this because that's what I want to name my book. But when you're working with academic publishers, they prefer, a more standard name. So how do you innovate your information technology? So I'm thinking the bleeding edge. How do you be at the bleeding edge but healing at the same time? So that came to me, and that's the title of what I'm using today. And I'm going to give you guys a challenge, because that's what we're here for, right? We're challenging healthcare. When I went from sort of the standard CMIO role into the sort of Chief Innovation Officer role, the person who hired me and created the role said, I was looking for the most disruptive person on campus. And I found you. And he was great because he really reassured me that's okay. I have your back. And we need to disrupt healthcare these days. So, I'll often say, there's a lot of angst over we have a shortage of physicians. Indeed, we do, if we continue with our current system. And so I say we don't really have a shortage of physicians, we have a shortage of using them efficiently. So my challenge to you today is how do we get over that? How do we start using physicians more efficiently, and indeed really using and thinking about the healthcare team? And how can we make that more efficient so that we can take better care, more efficient care, higher value, lower cost care of the patient population? In fact, how might we get to that scenario where the physician doesn't have to do everything, or as much as they do now, and how we can automate certain aspects of care, how we use the team more, and how we get to the point where a doctor sees less patients in a day, but takes care of more patients, what every other industry has done. How do we get there? I think it's innovation, innovative thinking is going to be a key to that. And so the agenda today is pose the problem and present the solution to you, making physicians more efficient. And we're going to talk about what is innovation, what does that mean, as well as give a variety of examples, because I'm a big proponent of stories. Because it's really hard to just dry didactic, this is innovation. I think it's so much better to hear from the voice of the innovators and hear about stories. I'm going to walk you through a variety of chapters in the book and some lessons learned, as well as some of what I've been doing at Northwestern, what I've seen nationally, and as well as the startup that I'm involved in, because that's been a great experience. Just like a lot of you here looking for doctors, I got involved with some young, smart entrepreneurs, and that's been just a fun experience over the years. I've actually probably been involved with a dozen plus startups, as well as 2 publicly traded companies. And so I've sort of been in your shoes and I've seen this before. And I think there are a couple of important things to learn from that. So what's driving this idea? What's so important is leadership. And we have leadership here. You have some of the elder statesmen. And that is going to be a huge proponent, because it's very hard to just throw in innovation. But there's no question. The reimbursement changes, moving from pay for volume to pay for value, is probably going to be the most important reason why leadership in cultures wants to change. And obviously information technology, and I'll talk obviously a lot more about that, but that allows us to do things quicker, better, cheaper than we ever could before. And it is what's going to drive. It is rarely the information technology itself that is the innovation. It's often the ecosystem around that. You'll hear me say that a number of times. That it's how do you change that culture, the process, the thinking, the reimbursement, the legal and regulatory issues, all of that often become much harder than the actual information technology. So that's important to remember. You can invent the coolest, greatest little thing, but if it doesn't align well with leadership culture, reimbursement process, etc., it's going to be very hard to make it successful. So what do I mean when I say how to be innovative? I often break that down into methodology, just like process improvement has a methodology. It's called Six Sigma and Lean. Innovation has its own methodology, which I've learned over the past several years, because I've been fortunate enough to move from sort of the classic informatics space and get involved in a variety of innovative activities and learn from some great folks, including design companies. And I usually say it's 3 parts. There's the discovery phase, that's where you observe, you learn, you investigate, and you come up with your idea. And then there's that incubation stage, where you take that idea and you actually build a prototype and pilot, and you go through rapid cycling till you get something that works, and then spreading it. Often the hardest part is actually spreading it. And these are the components that in one way you can say are formal methodology, but another way are informally infused within everything you're doing, whether or not you think formally or not. We saw in the book that most of the folks who did something didn't use a formal methodology, and yet you could map what they did to that methodology. How do you stimulate innovation? So if you're a large organization, find, fund, facilitate, are the sort of the 3 F's of stimulating innovation. And what we're doing here, right, is a combination of all these things. There's finding, the problem, finding the right people. There's funding, there's and facilitating. All of that's coming together. That's how a place like the Hoosier Innovation Challenge is able to actually move things along the curve. I think it's a fantastic way to do it. So the matrix is, the discover, incubate, accelerate, find, fund, facilitate. Each of them have their own ways. Do the book, right? This is something I spent a couple years on. And it is, first of all, give a lot of credit to my co-editor, Chris McCarthy, who helps lead innovation at Kaiser and was the founder and head of the Innovation Learning Network. And he and I are very close, good friends and colleagues. And when I was asked to write this book initially, he was the first person I thought of to help me. And thank goodness I somehow convinced him to do it, because writing a book is its own journey. And what we did was take what we each had learned. I had been backed by something called the Solozzi Healthcare Innovation Program that I founded about 5 years ago. And that was in honor of a patient and friend, Peter Solozzi, who was a creative director for business folks in Chicago, and often challenged me, how can we be more innovative, particularly around improving the patient experience and making things easier for doctors and better for patients. And so with some philanthropic funding, I was able to start this program to be disruptive and have the money to do it. Because that's often, even a little money can go a long way a lot of times when you don't have to go through the standard processes and filling out paperwork and saying what metrics you're going to improve. The Innovation Learning Network, we talked about, is a nonprofit consortium of healthcare organizations that come together on a regular basis and learn about innovation methodologies and learn about who and what everyone is doing, so we can get stimulated, educated, informed, inspired to go out and do things at our own organization. So when we put the book together, we recognized that we wanted to have folks contributing from the Innovation Learning Network, from the CMIOs that we know, and tell us what really they feel happened at their organization that allowed them to create something innovative. So we started everything around storytelling. And every chapter is a story. And actually there are multiple stories, because we did something somewhat interesting and unique. Besides having the voice of the innovator, the people who wrote and told us about it, we actually also created personas, which are really important in innovation. Personas, in this case, meant we created a family, Martinez family. We created them out of thin air, but we actually worked with a professional persona person who they're out there, and they actually created this family and described who the father was, what his values were, what type of job he had, what he thought about doctors, and the mother and the kids and some extended family. And we gave those to the authors and said, tell us what would happen to this family at your hospital, at your organization, with your innovation. So this poor family went through like 20 trials and tribulations in the course of the book, but they always came out pretty well because of the innovation. And every chapter starts with a discussion about how this family would go through. And some story, Susie broke her leg at playing soccer, and John, the father, he was having some chest pain, and what happened when he went to the hospital. So it's a fun way to make it very readable. Additionally, we asked each author to have standardized structure. Tell us not only what your innovation was, but how it started. What was the story? What was the initial thought? Was it coming to a meeting like this? And how you took that, what the arc was, to get to the point where you actually could see and feel the system working, and then how it was successful, how you measured it, how you spread it. What lessons did you learn? And the result, was, when we got all these together, we recognized there were sort of a couple of sections that became obvious. Why and how you can be innovative with electronic health records that you already have in place. How you can take advantage of all the telehealth and technologies out there. And finally, we said sort of advanced technology, the newer cool stuff, how that might work in the healthcare system. So the second chapter, we went through some of the methodologies, again, the formal methodologies, and talked about how you could do that formally, but in many cases, you can also, inherently, it just happens. If you use the methodologies, though, it becomes a little easier, and you can get from A to B more quickly. But if you don't, a lot of times the ones that succeeded wound up informally using the same methodologies. So the book, like I said, divided into 3 sections. And you can see with EHR, there was a lot around care coordination and a lot of what I call automation and delegation of care, from prevention and disease management, how you could transfer some of the knowledge to the staff. So again, making doctors more efficient by letting the staff take care of certain things. Automatic adverse event detection with telehealth. We had some of the standard e-visits and consults and patient portals. We went into home monitoring, and then some interesting things like telepharmacy, teletranslators, and then the advanced technologies will go into some more. So I'm going to quickly go through each of these chapters, being respectful of time, and there'll be some time for Q&A after if you have some particular questions about them, and try and give you a little highlight of what each of them look like. So the first section is how do you take that EHR, that boring electronic health record, so to speak, and can you be innovative with it? And what we're seeing is that you can, working even within the system. The first chapter is actually a chapter that I wrote. It was about what we've done with care coordination using simple messaging. But the idea is we change the process of care. Instead of making the doctor write everything out for a patient when they were going through, for example, we often use example of inflection points or new diagnoses. So the example I'll often use is hematuria, blood in the urine. Instead of making the doctor remember, okay, how do I work this up? I see this twice a year, I'm just going to refer to the urologist. Instead of actually having them do that and sort of tell the patient, you're on your own, good luck, we actually created a checklist that explained how they should work it up, what labs they should get, how to make sure they ordered an imaging study before they saw the urologist, to make sure the urology appointment was set up with a cystoscopy at the same time. But then we didn't make them go through and remember all of those things and do them all. We created a pathway, a template, and we built that into the system very easily. The messaging in EMR is easy. And by doing that, they just could initiate that message, send it to our care coordination team, who would then work that message. So the standard protocol would happen. Someone else would do the work of it, and in fact track and make sure that at the end of a month, if those weren't done, the doctor would be notified. So the result was we cut down the number of visits to the urologist, so we saved money. We made the urologist happier because that initial visit was sort of useless without the imaging study. We made it quicker for the patient to have everything done. In fact, we just published a study that showed we decreased the amount of time it took to complete that evaluation from 75 to... If then logic, they can present things to the physician. In this case, there were 2 examples. One, how do we create pre-visit orders so that if a patient comes in early to get their lab work, the doctor doesn't have to think about it. It's already accomplished. The system already predicts what they're going to need. Second is how to choose the right documentation when the patient comes in. Again, these are little things, but if you save a doctor a minute per encounter every day, that adds up quickly when they're seeing 30 patients. That's half an hour. That's huge for doctors. And it gives them more time to spend with their patients and less to focus on the busy work. Team bundling is just a concept that's used at Geisinger. What they did is, again, automate and delegate tasks to the team, and then they use this all or none bundle philosophy. And this is a cultural shift where they present to the users. You can see up here, when you're trying to improve diabetes care, it's not just one thing, it's a variety of things. And how do we get you, the physician and the team, to think about accomplishing a bundle of activities, not just one activity. And by putting that culture in and embedding it within the EMR, they were able to have a significant outcome. This one of my favorite chapters too, automated adverse event detector. In a hospital, every day adverse events happen. But unless someone sort of tells you, you'll never know. So what they did is they figured out they could use a back-end data report to find incidents that happen that are highly predictive that an adverse event happened. So example, if you have to give, in this case, the Children's Hospital, Narcan. Narcan is something that reverses the effects of overly medicating with pain medicine, with narcotic pain medicine. So giving that implies that someone mistakenly got too much pain medicine. Having to give extra glucose to a patient implies that their glucose went down too low because you used too much insulin. So they were able to find these things that were very reportable and that predicted what might have been an adverse event. But more importantly, again, that was the easy part. The harder part was creating a process to actually do something around. In this case, they had a nurse assigned every morning. She opened up the report, looked at what was going on, and then went out and did a chart review, talked to the folks to discover, was this really an adverse event? And if so, are there trends here? What can we learn? And in fact, what they did is an iterative approach. What they learned, lots of events happening in this scenario, let's change this scenario, let's change our insulin protocols, etc. And the result, you see a downward shift of how many times adverse events can happen in the hospital bed. A tremendous decrease that fell from 90% of all admissions who had at least one adverse event down to 30%. So, fantastic results from a relatively simple use and innovative use of technology. So let's get to the next section, telehealth. This is something that we're using in every other industry, and we certainly have talked about starting to use in healthcare. So part of the chapters, remember, don't just tell you about what the innovation is, but they tell you how they executed it at their organization. And that becomes so important. Because sure, it's easy to say, oh, e-consults, look, everyone knows how to do that, but you don't, because there are lots of little tricky parts to it. And what we started with was one of the first patient portals. Again, patient portals, not claiming it's a new technology or a new way to do things. They've been around for a while, but they've only been partially successful and adopted. So we went to actually Partners Healthcare on this one and said, you were one of the first to do this. Tell us what you've learned over the past 10 plus years. And one of the original contributors to the patient portal walked us through why they did, what they learned over time to be as successful as they are. So again, not every innovation is brand new spanking technology, but it is innovative thinking that's been used over the years. The virtual consult, again, this one actually is different. It's not physician-patient, which we'll talk about. It's physician-to-physician. This is becoming increasingly popular. And so again, we went to folks that have been doing it a long time, group health. What have you learned? How might you have done this differently? What are you looking at in the future? What they learned, by the way, was again, the technology is not hard. In fact, if you have an EMR, in the same EMR, it's simply a message from a primary care to a specialist. But the result is you'll decrease the amount of visits to specialists by 30 to 40%, which in a pay-for-volume scenario is not a good thing. Or if your doctors are being paid by their volume, even if the organization is capitated, not a good thing. Why would a specialist hurt themselves, so to speak? So what they did is they incorporated in an RVU, which is a way to measure work level, not just for seeing patients, but also for answering questions from primary care doctors. And the result was they rewarded the specialist for doing what the specialist sort of wanted to do, which was help the primary care doctor figure things out as much as possible and not have to see the simple basic stuff. Specialists like to see the really cool, complicated stuff. So if it's a real easy, basic thing they can take care of without the patient having to come in, even better. There are new companies and technologies here, if you want to think about challenges, that are trying to figure out how you do this in organizations that have different EMRs. FQHCs, particularly out in California, I was at a meeting last month, where the FQHCs, federally qualified health centers, who take care of Medicaid and lower income folks, are working with university centers to do this. They have different EMRs, so they figured out web-based technologies to communicate with the specialist and, if possible, get an answer right away. So not only is it more cost-effective, it's more efficient. It's easier for both patients and providers. And in this chapter, the VA system in Cleveland talks about the classic telehealth. In their case, how do we bring endocrine specialists to rural areas where we have lots of diabetics, but we don't have a super specialist? And by using Skype-like technology, again, the technology itself, not the hardest part. What was harder was convincing everyone to do it, coming up with the correct reimbursement model, and coming up with the correct clinical model. In their case, they talk about how they incorporated the nurse diabetes manager at the local offices to work in be in the room when they did this teleconsult. Sometimes the primary care doctor was there as well. So again, an example of how they walked through and made it successful. This one was actually from Memorial Hospital South Bend, so the local folks who have very innovative thinking, and they were basically challenged by getting a device that did home monitoring. And I love what they did. They put a constraint. Constraints are often good for innovation. They challenged their house staff and their doctors. They said, let's do this, but it cannot be for CHF, because everyone does it for CHF. And the high-risk OB doctors came up with this idea of what if we gave it to some of our high-risk OB patients, let them monitor. And this was one of the few innovations that was still very early on in the process. But what we heard were great anecdotes and stories about how a mother found her blood pressure was higher than it should be at home, and was able to come in and deliver earlier before it got out of control. Another example of a mom who found her glucose was dropping too low, and actually they were able to alert the nurses essentially before she fainted, and they were able to send out folks to revive her. This is one of the more interesting ones. Now we're getting into some of the past ones were how to succeed with innovative things over time with some standard things you've heard of. This one was pretty new though, teletranslators. I love this idea. What they did out in California was a bunch of hospitals, competitive hospitals, combined together and said, look, we need to have lots of translation ability. Each of us has so many translators, but what if we spread that translator risk pool essentially across all the hospitals? So not every one of us has to have a French or a German or a Hmong interpreter, but across our organization, 24 hours a day, we'll always have one of those at one of our hospitals. And then we use, again, Skype-like technology to allow that translator to sit in a room, see the patient, and translate for the doctor. Again, relatively easy idea, but creating it was difficult because of the competitive nature, who was going to pay for what, who was the legislative and regulatory things that had to be changed. And that was, again, that ecosystem that had to be changed. The technology itself was a one-day process, but building the model around it was so important. In an e-pharmacy, similar idea, a rural hospital, Via Christi, needed pharmacists for nighttime coverage and weekends, and there just weren't enough where they were. So they created a video into their hospital pharmacy, and they were able to, by changing a variety of legal, regulatory conditions, they were able to get pharmacists from all over the nation to provide the coverage that was needed. The last chapter, or last sections, are about advanced technology. So some of the cooler, funner stuff when we think about. This is UPMC's Smart Room. You may have heard about this, but the idea is they actually put a monitor in the room. This is one of my favorite stories about how it came to be. In this story, a woman was admitted to the hospital for some infection, and she needed an antibiotic. They had trouble getting the IV, and so they called the IV team. So this IV team came in, they're experts on getting IVs in patients, and they did their job. They took care of everything perfectly, got the IV in the patient, started the antibiotics. Well, the problem was that over the next couple of days, she developed a severe reaction on her arm because she was allergic to latex. It was in the EMR, but the IV team, they didn't look in the EMR before they came, and they used clear latex gloves. And this woman had a bad outcome. So they had a brainstorming. They went to that discovery phase and had a brainstorming session. And they sat around in a room and said, how might this have been avoided? And they said, come up with whatever crazy ideas. And someone came up with the crazy idea of, well, what if the walls were alive? When you walked into a room, and the room knew who you were, and based on who you were, showed you what you needed to know to complete your job. And we'll say, well, that's a crazy idea, but you know what? We can morph that into a monitor that's in the room, using RFID technology to read the badge of the person who runs in the room, integrate it with the EMR, and indeed show you what you need to know, and not only show you, but also allow you to input things. And that's what they did. And so again, example of small anecdote, a story that built into a passion for trying to change something. And the result is they actually spun this company off. Partners, again, we go to for mobile EMR, because again, they were one of the first and earliest to do this. And what did they learn along the way? Again, fascinating discussion of the technology and workflow and design theory that went into how do you build mobile systems for doctors. And let's see, chapter 17, I love this chapter as a discussion of how you bring checklists in healthcare. Are you all familiar with the checklist article that Peter Provenos has done? If some of you have heard that? Maybe some not? Okay, read it if you can. It will go one day. He was a fabulous writer and a surgeon, wrote about Peter Provenos and the checklist that he created for the ICU to make sure that people did everything you're supposed to do when you put a central line. And the result was a significant decrease in infections, and down to zero, basically, in the ICU. A great thing. What Gawande wrote was, if he had invented a pill to do that, he'd be a multi-billionaire. But instead, all he did was invent a process, a checklist on a piece of paper. Because of that, it's really hard to spread that. This is where information technology becomes so important. So in this chapter, they created a checklist around ventilator management. But they didn't just post it in a room on a piece of paper. They incorporated it into their information technology, so they're monitors across the ICU that anyone can look up and immediately see, is every patient green? Is there yellow? Is there red? Is there something that I haven't done yet for that patient? And by doing that, they've incorporated it, they allow it to be able to spread, and they make it more efficient. And so it's a great example where you combine the great ideas with information technology. George Reynolds, the well-known CMIO at Children's in Nebraska, is just a brilliant phenom on using dashboards. And he talks in his chapter about using just general technology for dashboards, business intelligence tools, but creating really smart dashboards that really tell you. One of my favorites is, here's a dashboard of dashboards. So that dashboard shows you what other dashboards and rules are being used to get a sense of how they're impacting the organization. So if you're interested in analytics and dashboards, that's a great chapter. Another interesting fun chapter, this one from Kaiser, where they talk about the patient panel. Right now, there's focus groups, and every hospital has a focus group meetings. They might have a patient advisory panel. It's like 10 or 20 patients at most. But what they have is 25,000 patients, because they sign them up online, just like every other industry may do. And granted, it's a little biased, because it's people who by definition are online, but more and more that represents a good proportion of people. And what they can do is, by signing all these people up, they can use technology to quickly ask, well, what do you think of this advertising slogan? Or what might you think if we offered this type of service? And they can get immediate feedback relatively cheaply and much more comprehensive than just asking 5 or 10 people in a room. The final chapter was about gaming. This is certainly a fun area, a little different than the other chapters. Where every other chapter where the people who did the innovation wrote about it, in this chapter we actually got some gaming experts who knew healthcare as well. And what they talked about was, what's gamification mean? How is it, why is it so popular and important? And then they actually gave about 5+ scenarios of real life examples where gaming technology and gamification theory were used to improve patient care, quality, even drug design. So it's fascinating thinking through that type of process and how that type of innovative thinking that how you get, if you have children or little brothers or sisters or you yourselves, we'll sit and play with games for hours. But struggling through electronic medical record or much of the information technology in healthcare, and it's boring, it's not fun. How can you make it fun? How can you make it appealing, interactive? It's something you want to keep doing over time. So, some of the common themes. In each chapter, we saw consistently, this idea of a bottom-up idea. Often comes down here. It's rarely that you have a CEO all of a sudden say, do this, and the top-down goes down. But eventually, as it gets spread and becomes useful, you do want that top-down support to make it work. Second, as I mentioned a few times, the ecosystem becomes much more important than the technology itself. Unless you're truly creating some, unbelievable new machine, the truth is most of what you're working on today is using relatively standard technologies, hopefully in an innovative way, but you also need the ecosystem to make sure it succeeds. The last is, again, something you'll hear me say a lot: happy doctors, happy staff equal healthy patients. I'm a big proponent of doctor happiness and creating systems and tools that make doctors and other healthcare workers make their life easier. It's the same philosophy that Southwest Airlines uses. They don't focus on the experience of the person in the plane, the passenger, as much as making their workers really happy. Because guess what? That works out really well. Because when your workers are really happy, your passengers are going to be happy. And when your doctors are happy and efficient, they're going to have more time and they're going to be able to focus more on the patient. So, a couple more stories. And I'm going to go through things that I've done and seen at Northwestern first. So I'm really fortunate at Northwestern. I still get to play. And this is one of the examples of where I came in and said, why don't we do this? And the usual, the executives were like, well, we know what would happen. They would steal them, they'd break, they wouldn't be any value. It's like, well, how do we know that? Why don't we try it? Well, we have to have metrics and processes. Well, no, I'll fund it out of my program. I'll get donations. HP donated some tablets to us. So we got that, so we just started it. The first person who got it, the nurse who was helping run the program on the oncology floor, said she walked in, these people who are on the oncology floor are there for weeks at a time. When she went in and gave him this tablet and said, it's yours for the duration of your stay, he cried. This is not what people expected. They're not what people are thinking, but these are unbelievable, important things that we have to learn. So we're going to watch and see what they do, but we're also going to try some innovative things. We're going to let them message and text to their nurses. We're also going to try and use Skype-like technology, telemedicine, to bring them into multidisciplinary rounds. So they can sit there on their tablet and actually see what all the nurses and other folks are talking about at the rounds, which are down the hall, but it's not easy to get all the patients in and out of there. That's not traditionally what's done, but we're going to see what can happen. So again, just an experiment, a pilot, no specific metrics. Very hard for an organization to do sometimes, but you need people to push those. So let me finish up with some advice for innovators. The way to be successful, I boiled it down to three things. One is you need that passion. You guys need passion. Ideally, you need to have a provider, healthcare person with you who has that passion to change something and do something better. Second, you need a sustainable business model. Not a shock, but really every startup is really just in search of a good business model because it just won't work otherwise. Third is how you can spread it, and spreading it with information technology is particularly important, particularly in healthcare, where change can be so hard, but this is where you have that leverage. So if you can do these three things, there's a much greater chance that you'll be successful, but also want to remind you that happiness for you guys, and you doing what you do at work, happiness for the customers and users that you work with, never forget that. It is so important getting adoption, and for you just to get through some of the brutal days of how hard it is to get through a startup. So I'm going to end with one more story, and that is a story I have about the startup I was involved in. And I titled this in PowerPoint Dreams Really Come True. Because 2010, 3 years ago, I presented at the Mayo Transform Conference, which is an innovation in healthcare. It's not technology specific, but I presented some PowerPoints that I had worked with, that I created with a couple of designers to go after what I said were some of the pain points for a doctor. Medication refills, dealing with labs. I said, how might we make that look different than the standard EMR, and how might we actually make that easier for doctors to use? And from that, I actually wound up meeting some entrepreneurs, just like you guys here. As I did my talk afterwards, 2 young entrepreneurs came up to me and said, wow, we'd love to work with you on this. And we talked to each other for a few months and said, let's start a company taking those slides and actually making a real company out of it. And so we formed HealthFinch, which winds up now being a cloud-based decision support tool that focuses on doctor happiness in figuring out how to automate and delegate certain workflows. And we started, indeed, with refills. And so we created a tool that actually takes refills, medication refills coming into the doctor's inbox, grabs them, runs them through logic that we've worked with the doctor, working with the EMR, completely integrated, and then send it to the staff to take care of, so the doctor doesn't even have to deal with it. It actually winds up being not only more efficient, but also higher quality because it holds to the standards that the doctor's chosen. And the result has been, we are trying to save doctors time. And we think we can save, in some cases, 30 plus minutes, that is essentially, again, going back to that first slide, making doctors more efficient. And so for every 20 or so doctors who use the tool, we create another new doctor because we save them that time. So I want to end with, and by the way, I'm happy to talk more about the struggles we've gone through, right? Going through the startup experience has been tremendous. But I'm going to just end with these quotes, which I think are important to remember because you will hit at various times snags and people who could care less about what you're doing, and all the typical things that startups go through times 10 because you're in healthcare. But the good news is you're not just creating some new social media tool for 22-year-olds. You're actually trying to change the world, and because of that, hopefully that will make you happier and eventually even wealthy, because healthcare is in the midst of the biggest disruption that we've ever seen in our lifetime. So good luck, congratulations on getting here, and I'm happy to do a little Q&A. Thanks.